Dr. Andrew Mulwa is the Acting Director of Medical Services for Preventive and Promotive Health at the Ministry of Health. Good morning, Dr.
Good morning.
Good to have you again on the show.
Thank you very much. I think the first time in the year.
Happy New Year. By the way, Happy New Year, Dr. You've been busy, I can imagine.
Quite a lot with COVID and all, vaccinations especially. Yeah.
Before actually we talk about TB Day, because that's the reason why you're here today, we're talking about preparations for World TB Day, which we'll be commemorating on Thursday. Vaccination. There are some 10 million vaccines that are not in people's arms.
Yes.
But we have 7.9 million people who are fully vaccinated so far. 17 million who at least received a dose. Yeah. So how are we doing? Is that a good progress or is that slow progress?
I think we must say we have done well, fairly well, in the beginning of the year, because now this is the week 10 or 12 or thereabout of the year, and in 12 weeks we have been able to do about 8 million vaccinations, which is fairly good performance. But when you look at now the granular data on daily vaccinations, after the mass campaign of February, beginning of March, the vaccination rates have significantly, of February, have significantly gone down. We are, however, because these are system issues, it's a programmatic issue. It's a question of are you reaching the citizens? Are you informing the citizens to create demand? Of course, the first responders have already been vaccinated. They have actually gotten their boosters. Now we are dealing with resistors. So we also have to change communication strategy. And in the coming days, I think you'll be able to appreciate how we are going to change the communication strategy and how we are going to engage the masses right from the community level, so that we create demand in those populations that have not been vaccinated. So
what's the main communication challenge? I mean, what are you hearing from the ground, those people who are hesitant?
The hesitancy is mainly around misinformations and myths that are around the vaccines, especially in the rural communities. When you look at vaccination rates in Nairobi, in Nyeri, in Kiambu, they are comparable to a developed world, 55%, 50% fully vaccinated, which is good performance already. Then the other thing is the perception of low risk. Everyone thinks now COVID is gone, and therefore it's not easy to convince them.
Thinking, they know.
They think COVID is here.
In their mind.
You know, I'm telling you, they know.
Yes.
It's because COVID hasn't gone anywhere.
Yes.
Okay? It's still with us. But their behavior is that it's a thing of the past. So that's someone who has internalized this false notion that COVID has actually disappeared, and it hasn't.
Indeed, it's true that the low risk, because infection rates consistently for the last 7-8 weeks have been below 1%. I think yesterday it was 0.2%.
Yes.
Which, but we should always remember, we closed this country when we had 4 cases. So even those 12, 19 cases are significant.
They are significant.
Because this disease began from one person, as far as we know. And we actually closed schools when we had less than 50 cases. So they are still significant, so therefore COVID has not gone. We had globally seen a period where we did not have a resurgence of the epidemic globally. And that was giving us some assurance that probably we are seeing the tail end of the disease. But now we are seeing what is happening in some of the Asian countries, and that is already a signal that we may be having a new wave. Is it Omicron Delta or something that is already emerging? So we don't know how it will progress. This is a disease. Diseases don't read books. Diseases don't know Dr. Mulwa. Diseases don't know boundaries. We have seen. So maybe the next 4 to 6 weeks will be significant in terms of telling us which direction this disease is going.
There's a cautionary note that must be applied to these situations. would you say that the ministry is doing enough to communicate this cautionary note?
The ministry, I think, and we have been. I think COVID-19 response, we have been as consistent as a government can be.
Without a shadow of a doubt, the cautionary note is now,
Yeah.
because we were excellent when it came to ensuring that we cordoned it off. Our management of COVID was excellent in many, many ways. That's not my worry. My worry is now.
We also have to look at this disease from now, not an epidemic perspective, but an endemic perspective. So how do we learn? How does the society learn to live with the disease just like any other? Remember, accidents alone in the period that we have had COVID have killed more people than COVID-19. So you also have to have a balancing act that we are not saying we are putting our foot off the gas, but we also have to now learn the communities, learn the population how to live with the disease. And that's why issues of quarantine, issues of isolation, we keep revising, because now we have learned the disease. At the beginning, no one knew much about the disease. Now we already have quite
some knowledge
about the disease.
We have some knowledge. And there's still other diseases that are killing people. The fourth most deadly disease in the country, fourth among the communicable maternal and nutritional diseases, is tuberculosis. We'll be commemorating World TB Day on what is it?
So,
Yeah? Are you okay?
I was just making sure CT was all right.
Okay. So far, since the beginning, since the first case was reported in the country, how many people have died of COVID in the country?
5,700, thereabout.
In 2020, 21,000 people died of TB.
Yeah, indeed, TB is one of the most killer infectious diseases in the world, accounting for 3 deaths every minute in the world.
Every minute in the world.
Yeah.
And in the country, that's also high, 21,000 people.
Yes.
So 140, I'm just looking at the statistics here, published in The Nation today. 140,000 estimated people who developed TB in Kenya in 2020. Among them, 17,000 were children. And they're highlighting the story here. Yesterday, CT, we were talking about the risk of blindness.
Yes.
And the ages even getting younger. There's a story of a young lady here called Christine Joki, who's now 24, who says, as the year began in 2019, she noticed that her eyes were not aligning properly, and therefore she was squinting whenever she tried reading signages on billboards. At first, I thought I just needed spectacles to correct the error that was developing, but even after getting them, I still couldn't read those posters. Situation prompted me to go back to my optician, who referred me to an eye clinic where I was prescribed an anti-inflammatory eye drop because the doctor who saw me said the dense, cloudy area that was forming around the length of my eyes resembled a cataract. When he dilated the pupils, he could see some areas in the back of the eye, which he suspected to be inflammatory, and therefore advised me to use eye drops to clear them. Took the drops faithfully, used them for about 3 months. Initially, there was a slight improvement, but it did not last long, and instead my eyesight just got worse. I could not even read notes that I had written myself. In 2020, schools abruptly closed due to COVID. I traveled from my rural home in Kakamega to Nairobi, where I was in school, and told my mother that my sight was worsening. Mother decided, no, we are not seeing another one. Let's go to Lion's Eye Hospital. The doctor who saw her gave her the shock of her life. He told me that he suspected I could be having tuberculosis of the eye, what he referred to as ocular TB. So there's TB in very many forms. And this is somebody who is basically saying she is going blind, and it's as a result of TB.
I think what is most common is and what people know is what we call pulmonary TB, which is the TB that affects the lungs, that presents as cough, difficulty in breathing, fever, weight loss. But indeed, there is what we call extrapulmonary TB, which can affect any organ of the body except the dead organs, which is hair and nails. Otherwise, TB can affect any organ in the body. TB of the skin, TB of the eye, TB of the mesentery, TB of the gut, TB of the lungs, TB of the kidneys, TB of the liver. TB can affect every living.
So what is
So what
TB?
exactly is tuberculosis? Dr.
Tuberculosis is a bacterial disease. It's a bacterial disease caused by a bacterium called Mycobacterium. And this disease, one, exists naturally and in the environment, and affects not just humans. There is TB of the humans. There is TB of what you call bovine TB, which affects animals as well, and therefore, and there is also cross infection. So TB can be cross infection. Humans can get bovine TB and vice versa.
Wow.
So so TB is a chronic bacterial infection, which usually is spread through air, which is airborne. So as I speak, the mycobacterium is spread in the air, and when it gets in the air, you breathe it in, gets to the lungs. From the lungs, it can get into the bloodstream. When it gets into the bloodstream, it can launch an infection anywhere in the body, in the brain, anywhere in the body, on a living tissue.
Okay.
And now, pulmonary TB is very easy to diagnose because someone will come with a cough, night sweats, all those classical symptoms of TB. Extrapulmonary TB, even for specialists, is not easy. So a lot of times, by the time a diagnosis is done, someone has been managed for other things, because you'll present with, let's say, for example, abdominal pain. By the time you realize it's TB, you have been treated for all sorts of abdominal issues. So you will present with a kidney problem. By the time it's diagnosed as TB, you have been managed for all sorts of kidney issues. The particular case is a case that you're just talking about. Someone presenting with ocular issues, with eye issues, will of course be managed for eye issues.
Yeah.
Because that's the index of suspicion. This someone has come. They only have a problem with my eyes, so the optician, the ophthalmologist will suspect common things that occur commonly, and therefore it is difficult to diagnose extrapulmonary TB, and even at clinical level, the clinicians have to have a very high index of suspicion for one to think this is indeed TB.
So this is not one of those that we say, go for regular screening and all.
No, because infectious diseases, unlike non-communicable diseases, you get the infection. Once you're exposed to the infection, you start exhibiting signs and symptoms of the disease. Then it's from there. Then you get you get screened by a professional, health professional. Then that screening, of course, must be. If you come to me and I think you have malaria, I will treat you for malaria. However good I am, if you come to me and I think you have you have COVID-19, I treat you for COVID-19, even as a clinic, because all the tests that I'll do will be to confirm whether indeed you have it. And sometimes you do empirical treatment where you have a differential diagnosis, and TB. A lot of times, especially TB of the children, is very, very difficult to diagnose.
Is there a specific test, Daktari, that is done? You know how you have the malaria test or you have the COVID test, is there a specific test for tuberculosis?
Yes, there's a sputum test where sputum is tested for the you do microscopy for the bacterium. Then there is also what we call gene expert now, where there is a machine that's able to get the genetic material of the mycobacterium. So I think that's now the mainstay of diagnosis. When you do a chest X-ray, because all these are able for someone who has a lung infection, you are able to see characteristic chest infection or opacity in the chest that will tell you this is suggestive of TB. You also have like now TB of organs. You have to do biopsy. You have to take a tissue and now do microscopy to determine whether it did it's TB. The beauty about TB is it's a chronic illness. It also gives you classical signs. classical signs like lymph node. When we're doing clinical examination and you examine someone and they have enlarged lymph nodes, and they are not gaining weight, they are losing weight that is unintentional. If it's children, they are unable to thrive. You have to high index of suspicion this is TB. Then those other tests come as confirmatory tests.
You know, I smile and I laugh as I'm listening to you. As I'm thinking of a term I came across once called comorbidity.
Yes.
You see, everything that the doctor is saying are things I used to hear with people who are HIV positive. Somebody doesn't seem to get well. Yes, they have TB, but even when they're put on medication, the improvement is nothing significant. And all this time, no one has tested them for HIV. So when tested for HIV, they realize, okay, you've got this, we understand, but you have another problem, and it is this one. Now, do we have a system within our healthcare processes where when somebody has a certain symptom, that we consider the possibilities of the very many things that could actually have the same symptoms and look into it? Or is it that by the time you're appearing before a clinician, the clinician is so battered with so many things that they are likely to deal with what seems to be most apparent?
I think the training of medical professionals is a complex, and that's why it takes 6 years, and even for diploma courses up to 4 years. That is exactly the training. That when you go for training, you are trained on how to look at the patient holistically and look at all the possibilities. There are thousands of diseases. So when you come to me, I have to have in mind this. From what you tell me, is when now I start narrowing down what are the other possibilities. So that's why we don't create a diagnosis immediately. We interact with the patient. We get an impression. Then you say, I have an impression this could be HIV, but I have differential diagnosis of 1, 2, 3. So when I send you to the lab, when I am doing my clinical examination, when I am doing sending you to the X-ray, I am now trying to narrow down of these 10 possibilities. That is the training of clinicians. And we have guidelines, we have protocols for management. If you look at the TB guidelines that we were launching last week, you will see these possibilities. So by the time you present with these 3 symptoms, these 5 symptoms, these are the differential diagnosis, so that we don't miss. Because remember, there are other diseases, even cancers, lymphomas, that can present like TB. So you need to have in your background that as I look for this, there is a possibility that there is also these others. So that's what we call differential diagnosis. So before we confirm the diagnosis and say, indeed, this is TB, we have to have a differential diagnosis.
Are there people within certain environments that are prone to getting tuberculosis?
Yes, people in congregate settings where who stay in areas where there's congregation, people like areas like prisons, people who also have HIV. You already mentioned HIV, TB co-infection is a major issue, and in fact the resurgence of TB in the 1990s, because we had sort of won the war against TB up to maybe late in the 90s, when now with emergence of HIV infections and immunosuppression, we have seen a resurgence of TB. So then that's one thing. Then when you stay in areas that in places where aeration, just windows, free-flowing air is not up, you are more likely. When you get exposed to someone who has TB for long period, in a place that then the risk of infection goes high. So in other words, what I'm saying, in people who are in congregate settings, where overcrowding, where aeration is not possible, these are environments where spread of TB is higher.
Okay.
So this is almost everywhere.
It's everywhere. That's what I was going to say.
Because you'll talk about schools. So how many millions of children are in school? Okay, that's one setting. You talk about
Prisons.
And that's why the classrooms need to be well aerated. So because I said this is airborne. So where there is flowing air, chances of infection are very low. where there is no flow in air, like prisons where there is no air actually in most of the places, then spread is very high. So where there is free flow in air, you should not be worried much about the numbers.
Okay.
Yeah.
Just a quick one. We know that TB is one of then the opportunistic diseases for HIV. Are there then situations where by virtue of your immune system being depressed or deficient, then you could get TB? So do we then see, for example, children who have poor nutrition, children who may have been sickly because of other issues, are they then at a higher risk of contracting TB, removing the HIV factor?
Yes, indeed, that's true. That's true. When you have immunosuppression of any nature, because remember, TB is the first vaccine that you get at birth. That's why BCG is given at birth, because it is anticipated that by the time you take your breath for the first 3 days, you are already exposed.
You're
to TB.
exposed.
Okay.
So all of us seated here have most likely been exposed to TB. And because you have been vaccinated against it, the TB stays in what we call latent form in the body. So when your immunity goes down for some reason, you don't have to get infection from elsewhere. You will get infection from the
latent
TB
one
that is
inside
already
you.
in you. But your immunity is able to manage it until you're immunosuppressed. So that's why TB in populations that have immunosuppression, that have malnutrition, becomes an issue, because you have been exposed to TB from the environment. It is already new, but when you are good, your body is able to take care of it. But when your immunity goes down, then the TB now resurges. And that explains why the HIV TB comorbidity is very, very common. And we give actually, in some of the immunosuppressed patients, we give sometimes prophylactic treatment against TB. Prophylactic means you give so that to prevent an infection. Yeah, because this person has a high chance of getting the disease, so you start giving drugs to prevent them actually getting the disease.
It's 7:30. Let's take a quick break. We are looking towards commemorating World TB Day on Thursday, but today we are here to understand what the Ministry of Health is doing in preparation for that. The Acting Director of Medical Services in charge of preventive and promotive health at the Ministry, Dr. Andrew Mulwa, is our guest this morning, talking about TB, and any questions that you may have on TB, you can post them on our social media, SpiceFM KE, on Twitter, on Instagram, on Facebook, and also on YouTube, where we are live streaming the show. Let's take a break. We'll be back shortly.
This is the Situation Room.
We're talking about tuberculosis. Doc, you've said TB is one of those that are very difficult to diagnose. Now, in the case of non-communicable diseases like cancer, like diabetes, it matters at what stage you get diagnosed, right? In terms of now the treatment that you go into. Is it the same for cases like TB?
Infectious diseases, fortunately, have TB, you have drugs. Of course, risk of complications. When TB is diagnosed in good time, treatment is always available. Even late diagnosis, treatment is available. The challenge is when you do late diagnosis, the challenge comes in with the lady you just talked about. She has to live with a complication, loss of eyesight.
So this cannot be reversed. If it gets to a point, ocular TB, you've lost sight.
You have lost sight because it has affected the nerves, and nerves don't regenerate. So even if you treat the TB, one has to live with some level of disability. But if diagnosis had been done early and treatment initiated, we would not get the complication. So TB is 100% curable. That's a good news. We, of course, have cases of multiple drug-resistant TB and XDR, which is now TB that is resistant to the commonly used drugs. We have first line, second line, and probably I'm talking about resistance to second lines.
Okay.
What brings this about, this resistance?
Resistance means this TB, one, has been undertreated, and therefore the bacteria has developed resistant. It's no longer responding.
Okay, what do you mean by undertreated?
Like, for example, I said this is a bacterial infection.
Yes, it is.
So when you take the usual antibiotics, it is affected. When you underdiagnose, you diagnose, I come with TB and I think it's pneumonia. What do I give you? Antibiotics. Antibiotics will actually slow TB.
Progression of.
But they will not treat TB. So what happens? The TB is slows down, then starts to mutate or develops resistance against the molecules. Or you are supposed to take dosage for 3 months, 6 months. You take for 3 months and you feel you are okay, you stop. Then the TB will have disappeared, but will not have disappeared. You will have no symptoms, but TB will have now
You've
mutated.
only suppressed it.
You have only suppressed it. Then it mutates in response to the drug that you are giving it. So the next time you get an infection or you spread that infection, it is not the TB that was responding to treatment. It's a TB that is not responding to the usual drugs. So, and the cost becomes extremely. To treat a TB patient probably costs about 20,000 or thereabout.
Yeah.
To treat multiple drug-resistant TB will cost maybe about 1.5 million.
Dr. Which is the most prevalent between the two reasons for undertreatment? Are we looking at undertreatment because of a miss or poor diagnosis, or are we looking at poor administration of your medication?
I would say, because I do not have advantage of having looked at studies, but both contribute. Where, because of poor, let me call not misdiagnosis, poor diagnosis. You treat, you undertreat because you think it's not TB, you think it's another infection, then someone feels they're okay.
But why would you think that it was another infection? Which goes back to an earlier question. Why would you think it was something else if you have the test and this person has been presenting with certain symptoms based on the impression that you talked about?
I think I said diseases don't read books.
Sure, but you also said that you get an impression
someone
as
will
a doctor.
present you, and I'll give you a classical example of a friend that I will not disclose, who is very close to me.
Okay.
Had diabetes. Diabetes. Newly diagnosed, 53 years, diabetes. So they go for treatment. Then they glycemic control, their sugars under control, but they are losing weight. They lose weight. Of course, the doctor will think cancer. They screen for cancer, nothing. Doctor thinks, could this be TB? This, remember, is after 6 months or so. Could this be TB? The doctor says, they look, they test sputum, they do gene expert, nothing. And this guy is still losing weight all this time. Then they go, they seek a second opinion. After 6 months of TB treatment, and they're still losing weight.
Oh, they've treated for TB now?
Yes, because you have
6 months.
presumptive treatment, because you have looked for what else could be causing these symptoms.
And it may be just one of those diseases that is
Yes.
well hidden, but
Yeah.
it's actually
Yes.
there.
So it does not respond. Then way later, a second opinion, third opinion, fourth opinion. Of course, he has seen. So one would expect someone would have seen
picked
so
up
many
something.
doctors. All of them. We actually realized it's one of the drugs that that was causing the weight loss. One of the diabetic drugs.
Oh, wow.
Which was causing as a side effect, which is a rare side effect.
Wow.
So this is now
was
after
no TB.
1.5 years.
Of
So,
even going through TB treatment.
why I'm even going through a full cycle of TB treatment? Why I'm telling you this is because sometimes patients don't present with what we know as classical symptom. You get 1, 2, 3, 4. It gives you this. No, diseases are complex.
Indeed.
Someone will actually present with pneumonia,
And yet,
indeed it is actually pneumonia. You treat pneumonia. You do your test. It's negative.
but the person is still.
But still, the person is still positive. So it is. There are many reasons that
How do
you do
they-
a chest X-ray and you have what is called a typical chest X. The chest X-ray looks good, so you think, okay.
How did they figure out that it was the drug?
I'm telling you, that was after like 6th, 7th opinion. So someone just went to research what could be happening.
What is this person taking?
What is
After
this?
all these...
After 1.5 years. At that time, the person I'm talking about was on wheelchair. He
Has lost a lot of weight.
He had lost like 50 kgs.
Oh my goodness.
And emaciated. After withdrawal, he picked up. You meet him today, you know.
You wouldn't believe it. So a couple of weeks
Diseases
ago, we
don't
had a
breed books.
conversation, right? We had a conversation about antimicrobial resistance, right? And saying that the major cause of a lot of the resistance that we see is one of the things that you've mentioned now about not completing a dose. You feel better after a period of time. And then you say, okay, well, chuck the medicine, I can move on. Is this a major issue with under treatment when it comes to tuberculosis?
Is a really globally is a major issue. Even in our country, is a major issue. Remember, anti-TB drugs you take for a long time, between 6 and 9 months. I think now we have regimens that one would take for 3 months, which makes it even easier currently. But to take pills for 9 months, and it's not one pill, it's several pills, it's not easy for anyone. Remember, we come from an environment where the health-seeking behavior is poor in the first place. That you only go to a health facility, to a health worker, when you indeed feel sick. In fact, the first thing, if you fall sick, that you think is, let me give it 2 days, it may disappear. That's our natural thinking.
More so in men.
Yeah. You give it 2-3 days. Sometimes you say, okay, it's now better. So
shake it off.
Yeah, shake it off. You know, that's the kind of health-seeking behavior environment that we are in. And therefore, it is not easy for us. And sometimes over-the-counter treatment that we go over the counter, you have this feeling, you say, give me, especially now even this period of COVID, people have azithromycin or all those sorts of stuff in their houses. So you self-medicate. When you go to the doctor, sometimes you don't even do the disclosure that you have done self-medication. So the doctor begins. So that is how under treatment causes. Then, of course, issues of adherence is an issue. That's why in the TB has a program. And we have what we call directly observed therapy. We monitor patients, we give them doses, we follow them to ensure that we even have community health workers. For some of these clients, we follow them to their homes and actually observe. TB treatment, the first few weeks, you observe the patient swallow the drugs.
I have to ask
To
you this
make
question.
sure that
Make sure
Make
they're
sure that the
actually
patient
taking
actually
them.
takes the
Again, I
drug.
have to ask this question.
Yeah.
Has the ministry increased the workforce of the community health? Kenyans is the moment I feel better, I stop taking medication. Because medication is supposed to be for when I'm really feeling bad. Now, if there's no one to follow up or to communicate what I'm supposed to actually do beyond the clinic, then to get the full benefits of the treatment or to get the full benefits of what it is that we are seeking to achieve will actually not be achieved.
I think from ministry perspective, we have over 90% coverage of community health workers in this country. And we are establishing what we are calling the primary healthcare network, where now the level 1, which is now the community level, is linked to level 2 and 3 and level 4, so that we have a hub and spoke model where we have the level 4 or 5 facility that is linked to several level 2s and 3s that is linked to several community health units. This system, we have over 90,000 community health workers today, all of them trained.
How many thousand?
90,000 currently in the
Across the country.
Across the country.
These are direct Ministry of Health reports.
Yes, these are now. And remember, health is devolved.
Yes.
So we have to work with the counties to ensure that, because the training of healthcare workers has happened. We have trained community health workers in every village in this country, save for maybe 10%.
Every village?
Yes.
So if I go to my village and
ask who is the community health worker, they will show
I'll
you.
be told.
Utaambiwa daktari wa mtaani. They are there. The challenge that we have had with this community health system is sustaining them. Because one, we call them community health workers, community health volunteers. Some do not get anything. So to move from one household to another, one needs a stipend. There are some counties that have started giving stipends long ago, others that have just started. The vertical programs, where HIV program is one of them, in every county has community health workers, in every sub-county around facilities.
Right up to the village level, as you correctly put it, yes.
So we have people who we have engaged. We have a mechanism of giving them some stipend, supporting them through our partners, so that they are able to do this work. Because to move from one household to another, observing whether these patients. But the beauty about the TB program is we can account for every single client on treatment in this country by a click of a button. I can tell you, patient so and so is getting their treatment in this facility. They are now 3 weeks into treatment. They are being followed by this CHV. This is the health worker. For TB, we have that
everywhere across the country.
Everywhere across the country,
both public and private.
Both public and private.
You know, one of the things about the TB program, and one of the reasons why COVID treatment and the management by the ministry took such a beating, is because of the efficient way the ministry has always run the TB program. I mean, when they set off, it is so well coordinated, and everything that they set out to do actually gets done. This is the really strange thing. So when COVID came about, I was wondering, wait a moment, but the ministry is able to do this thing very efficiently.
You already have an infrastructure in place.
Yes, they do. You will be amazed at how they coordinate with the partners and how they actually work. Now, which brings me to the question that I want to ask, having praised the ministry for this wonderful work that they do. COVID, ensuring that we maintain the low prevalence that we have, making sure that community health workers whom we've trained are equal to the task and that they do what they're supposed to do. What is the government program for this? Because right now what we have is a gain, and it would be a wonderful thing if we just maintained it.
I think I'll start by saying the last 3 weeks, we have been out in the field engaging communities, now community health workers and communities, on this messaging, telling them how to ensure that the communities, and remember in urban and city areas, it is difficult, fairly difficult to have this system. But when you go to the rural setup, it becomes very easy because the communities have places where they meet, they have ways of communicating, they have those chamas, they have all those things that they do on a daily basis. So we have been engaging the community health workers. Of course, communicating to them the risks of COVID-19, telling them the realities, showing them how to sustain or to maintain what you are saying. Then also embracing upon them the value of vaccination. I talked about that at the beginning of the show. Our major problem in the TB program, because I have to mention this, is the numbers that are undiagnosed out there continue the epidemic.
Right.
Continue the infections. Because in our country, we have about 140,000 infections in a year. We are only able to get about 77,000. So which we have 40% out there that is undiagnosed.
And is this as a result of them presenting to a medical facility with symptoms? That's how we're able to get them.
Some will not, these statistics are from us, from simulations. We know from the cases. They are not like people that we know and we have let them go. But these are estimates based on modeling. So in this country we have this number of people. So if we reach 140,000 people, then we have reached 100%. No country has reached, even developed countries have reached 100%. But we should be as close as possible to the 100%, to 140,000. 140,000 the patients diagnosed of TB in every year.
What's it going to take to get that?
What that means is we only get just 60% of the real cases. Maybe misdiagnosis, self-treatment, there may be unexplained deaths in the community. Those are the things. TB, infective TB, is 100% fatal. You get active TB infection and you don't get treatment, you 100% die.
Wow.
So that's the gravity.
By dying 100%, City, what does that mean?
It means the option of resurrection is zero.
Oh, so that
From
one
what
would
where
work.
I say it means if you're 100 people and all of you get infective TB and
All
don't
of
get
all of
And
you
don't
are
get
dying.
treated. However, if you do get, I mean, I think
Yes.
even as
But
even
if
as
you do
scary
get
as that
treated-
is, there's this other side of it to say that if you get it and you're diagnosed and treated, you
100%.
could recover 100%.
No, not you could.
You
If
will.
You will 100%. Yeah.
You will recover.
Yes.
100%.
Yes.
Right.
So what is it that then the ministry is doing to capture this 40,000?
One of the major challenges as we have had these issues has been diagnostics. That the microscopy that I was talking about, sputums, do not get us a lot of times. You miss. You maybe get 80%, so you miss the 20% from diagnosis. Then the other thing is a training of healthcare workers on TB, so that we build their capacity on TB, so that they know when a child comes to you, they are malnourished, they have not gained weight, and they are not coughing, they do not have fever, the classical signs. You suspect TB, then you start screening for TB. So we have capacity building, diagnostics. We are now using Gene Expert, and we have Gene Expert now in every county, and we are acquiring more, so that we even move to the sub-county, so that in every sub-county we are able to do Gene Expert. Gene Expert is a new technology. It will, just like the COVID-19 test, it will 99.9% pick, and it is not human dependent. Remember, microscopy is me and my eye and what I am able to see.
Yeah.
So if I don't see the AFBs and they are there, you will not tell me should have seen, because it's human. It's
Somebody else could see, though. You're looking through the microscope.
Yes.
Right.
So it's a question of then also the technique and all that. But now Gene Expert is able to pick. So we are
So you're saying we have in every county.
in every county.
So let's say at the level 5s and level 4s.
and level 4s. Yeah,
So, but we still need more.
we still need more.
How much does it cost to get one Gene Expert machine?
I'm not an expert in procurement and finance, so but it's quite pricey. It's quite pricey.
So it's relatively
It's
expensive
relatively expensive.
to get this.
Yes.
Where I look at another disease which Kenya has been able to handle very well, polio, right? Vaccinations. I mean, we saw the campaigns very clear about what needed to happen. This seems a little bit more tricky. So I wanted to ask, where does vaccination play a role in all of this? With other diseases, we see that you get the shot BCG at birth, but then there are boosters for children for other disease for other diseases that your boosters. You have the 6-year-old, 9-year-old, even as high as 15 in some cases. Where does vaccination play a role for TB, or does it at all?
Vaccination actually is what has made the globe contain TB, and BCG is the first shot that every newborn gets. And when you develop immunity, is a life attenuated shot. So therefore, when you get immunity at birth, you are able to carry that immunity
For life.
lifelong.
Okay.
So in terms of the science of the vaccine, you don't get boosters.
So are we saying those who are getting TB today are those who have not been vaccinated at birth?
No, I think I told you, and I said when you get, I said all of us
Are exposed
are
to
exposed
TB.
to TB.
Yes.
But the immunity is able to take care of it. So those who are getting TB may have the vaccine, but have an issue with immunity,
because
so
of other issues.
that's where that's where now the disease breaks the barrier of vaccination. So it is and one vaccination is enough from the science of vaccines. So it's now the body immunity, and every time someone gets a TB, there is a compromise if they are vaccinated.
And you treat
But
it
Charlie,
immediately.
there's something I'd
Immunity.
like you to help me understand. There are many people who've gotten these booster shots, and what they complain about is the after effects.
Booster shot of
The
what?
booster for COVID.
I've gone to COVID now.
Oh.
We have left TB.
Okay.
I'm on COVID.
Okay.
They've gotten the first two, then they've gotten the booster. After the booster,
They have.
you actually feel unwell.
Do you know why?
That's what I'd like you to explain.
It's simple. It means your body is already primed. Your body recognizes COVID-19. So it has immunity against COVID-19. That's actually what it means. So when you get this booster, the body reacts because it already knows that
Yes.
once this enemy comes, I have to fight. The body, while that helps it develop immunity, when you get that jab, the body is saying, oh, you have come. I have always been ready for you. I am going to fight you.
My mother had warned me about you.
Yes.
You're the one that my mother had warned me about.
So that's the mechanism of vaccines. That
That's it.
And so when you're feeling unwell, it's now your body
your
dealing
body,
with
yes,
your body
dealing with
dealing
it.
and
with
it actually says that the first vaccination has had an impact on
An
you.
impact on the body.
Yeah.
Daktari, thank you very much for joining us today. And as we commemorate World TB Day, we'll be remembering all this information.
Thank you, and welcome to Machakos on Thursday. We'll have the national celebrations in Machakos on Thursday at Machakos town, Machakos Stadium, from 10 to 1. Welcome the public to celebrate with us. We'll also have county and sub-county celebrations across the country.
Okay, I'm not sounding political. It's not a political statement, but Masako tunakuja, Masako mbe. Good morning.